Please be seated. We will begin shortly.
Comments from the podium, and then I'll come sit down. Welcome back to those of you who are staying to the bitter end. Thank you so much for being here. I will make an invitation I have made before. Those of you in the outer reaches, come on in, feel free to get cozy. We have a smaller group. The other thing is this session will take questions and answers, so we have 2 stand microphones. If you want to be a little bit closer to those to be able to interact, that would be wonderful. You've probably met me already, but for those of you who may be online or new, I am Dr. Michelle Schreiber, one of the Deputy Directors of the Center for Clinical Standards and Quality, and I am truly delighted to be joined by my dear colleagues and friend in this case, from across the federal government, and of course, patient safety advocates, because all of the work that we do should be with the patient at the center of all that we do. In today's session, we've brought together really our federal partners to talk about advancing quality and safety. I'm going to be moderating rather than speaking because you've spent the last 2 days hearing about CMS's plans. I want you to be able to hear from across the federal government what is going on within HHS and really across the federal government, the VA included, but also again hearing the patient voice. There is, however, a lot of effort at aligning this work across agencies, and that is really the message that I want you to take home. Let me introduce to you, I'll go in order. Marty Hatlie is an attorney by trade. We won't hold that against him. with other doctors sitting here with you, Marty. He is one of the co-founders of the Patients for Patient Safety US branch. There's a World Health Organization branch, and really this is a great group that is doing a lot to be patient advocates for patient safety, to do no harm to patients. So Marty, thank you for being here. Dr. Arjun Srinivasan is, let me see if I can get your title correct, the Deputy Director of Program Improvement at the Division of Healthcare Quality Promotion at the Centers for Disease Control, so the CDC. Arjun, thank you for being here today. Dr. Craig Umscheid is the Director of the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality, AHRQ. And finally, Dr. Ed Yekel is the Executive Director of the National Center for Patient Safety at the Veterans Health Administration. And if you're not familiar with this, the Veterans Health Administration really approaches safety from a national point of view and has a coordinating center actually in Ann Arbor, Michigan, where they really look across all of their hospitals and facilities for patient safety. So it's very exciting, and I hope Ed's going to share with you some of their high reliability work as well. So again, I'm turning this to my colleagues. We're going to start in order of agency alphabet, so AHRQ, then CDC, then VA, and Marty will then wrap it up with, so what do patients really think of all of this, and what are our opportunities? Craig?
Thanks, Michelle. I really appreciate you inviting AHRQ to participate on this panel. It's a real pleasure for us. Like Michelle said, I direct the Center for Quality Improvement and Patient Safety at AHRQ. We're one of the 3 centers that make up AHRQ. For those of you who are less familiar with ARC, ARC is one of about 11 agencies within HHS. We've historically been the lead federal funder of original research in patient care quality and safety, but we do a lot of other activities as well. We support practice improvement initiatives, measure development, data analysis. So I figured I'd give updates about what ARC is doing in the realm of safety in all three of those areas today. In terms of practice improvement initiatives, we're currently recruiting hospitals into 2 practice improvement initiatives nationally. One is called IDEAS, Implementing Diagnostic Excellence Across Systems. And this is an opportunity for hospitals to pilot and evaluate any one of 3 diagnostic safety toolkits that ARC has available. You could learn more about that opportunity by simply Googling ARC and IDEAS project, and you can learn more and enroll. We have another national implementation opportunity around preventing healthcare-associated infections. It's called the ARC Safety Program for HAI prevention. We just finished recruiting our first cohort focused on preventing central line-associated bloodstream infections, but we'll be starting to recruit our next cohort around preventing catheter-associated UTIs in August. So again, you can Google ARC and HAI Safety Program to learn more about that program, enroll. In terms of measure development, we have a number of updates to provide. As many of you may know, ARC helps develop and update the patient experience, or the CAP surveys. So we have 2 new CAP surveys that have recently been released. One is focused on measuring patient experience in the outpatient mental health setting, and another is focused on measuring patient experience at the end of life, and the survey goes to the family caregiver. We also have a new CAP survey in development for individuals who are admitted to the hospital for labor and delivery. So be on the lookout for that in the near future. As many of you may know, ARC also supports the survey on patient safety culture, and we have a webinar this coming Tuesday, July 8th at noon, that focuses specifically on how a new Pulse version of the hospital survey on patient safety culture can be used to help institutions meet the new CMS patient safety structural measure. So be on the lookout for that. And then lastly, in the measurement domain, we have the patient safety indicators that we maintain, and we've had a national advisory group evaluating those patient safety indicators with public input. And a report will be released in September that provides recommendations about what changes we should make to the patient safety indicators, including what PSIs should be retired and what new PSIs should be developed. We'll also in September be releasing new draft technical specs on diagnostic safety measures for the first time, so be on the lookout for that. In the area of data analyses, there is a congressional report that we recently completed on the burden of sepsis in the United States. And we recently updated that report and built an interactive data visualization where you can look at sepsis incidence and outcomes over time. And you can also look at how sepsis incidence and outcomes change across states. So I'd encourage you to look at ARC's resources around sepsis. You can just Google ARC and sepsis, and we have a whole web page dedicated to our sepsis resources. Lastly, I just want to emphasize that ARC continues to lead the National Action Alliance for Patient and Workforce Safety on behalf of HHS. This is an alliance of federal partners, all of whom you see on the stage today are key members of that alliance. You can learn more about this alliance by going to arc.gov. And the wonderful thing about the alliance is that we've been able to organize all of the federal tools that can help you meet your patient safety needs onto one site. We've organized those tools by CMS Patient Safety Structural Measure domain. So if you're having challenges in a particular domain, you can look to see what tools are available from the federal government to help you meet or achieve success in that domain. We also have webinars from across the last year plus that feature healthcare systems who have used those federal resources to improve safety in their systems. And we have a national safety dashboard where we're tracking national safety measures over time. So you can learn all about that on the AHRQ.gov website. Thanks, Michelle.
Thank you. CDC.
Yeah, thank you. And thanks to Michelle, thanks to the entire CMS team for also giving us the opportunity to present here today, build on that theme of collaboration and talk about some of the different areas of work where we're engaged in the healthcare safety and quality space. You've heard a little bit about one of the big ones for us, and that of course is quality measurement through the National Healthcare Safety Network. Abby gave a wonderful presentation yesterday talking a little bit about the things that we are doing with the National Healthcare Safety Network and the transition to FHIR-based measures, digital quality measures, and that is really incredibly exciting work. And I think one of the things that I like to emphasize about the National Healthcare Safety Network is that it was born as a quality improvement system that later became a reporting and payment system. And that is, as you guys know, a little bit different from a lot of the things that we have in medicine where the payment system that was created. We created the system to improve payment and later imposed quality on top of it. This is the other way around, right? This is a quality improvement system that also serves the purpose of public reporting, of payment, of quality measurement. And I think that is really important because that is the lens through which we view the data in NHSN. How can it be actionable for quality improvement? And a lot of our work now really is moving into the space of digital quality measures of FHIR, and that is really an incredible collaboration that we're having with Michelle and her team at CMS, really thinking about how do we develop measures collaboratively. And the best example of that is the sepsis outcome measure, where that is really a measure, shoulder by shoulder, CDC and CMS are working together on that measure, on sepsis outcomes. We're excited about that. It's going to be a big leap forward in sepsis measurement, and it's a great example of the way that CDC and CMS envision working together on these measures. We have others, for example, you saw glycemic events measures, VTE, venous thromboembolism measures. And so increasingly, we are expanding the measurement work of the National Healthcare Safety Network beyond just healthcare-associated infections and antibiotic resistance to some of these other really important patient safety outcomes, again, in really close collaboration with the team at CMS. And I think that is an exciting development, and it's all, again, built on how do we collect data that is actionable for quality that also serves the needs of transparency, of public reporting, and payment determinations, quality payments. And so that is all the work that we're doing in the measure development space. Central to our work remains the prevention of healthcare-associated infections and the reduction of antibiotic resistance. You've heard from several presenters here today what a success story that has been, right? The reductions in central line-associated bloodstream infections, catheter-associated urinary tract infections, Clostridioides difficile diarrhea. We've seen real progress in a lot of those infections. There is much more to do in that space. We view that work as being in kind of two domains. One is continuing to make sure that everybody implements the things that we already know work to prevent these healthcare-associated infections. As Don Berwick said in his talk today, right, we know how to prevent central line-associated bloodstream infections. We need to make sure that everybody is doing all the steps to prevent those infections for every patient, every time. But then it's also understanding what are interventions that might help us prevent infections that right now are not meaningfully preventable. And so that's both things like central line-associated bloodstream infections that we don't yet know how to prevent. There are a small number of those that we can't prevent through the things that we have. So it's developing new interventions. But it's also continuing to assess other types of healthcare-associated infections. A big one, as you all probably know, are healthcare-associated pneumonias that are not related to patients being on ventilators. There are large numbers of patients who go into the hospital who get pneumonia in the hospital, not associated with the ventilator. It may be one of the most common types of healthcare-associated infections, and we're thinking about how to measure that, and most importantly, how do you measure that through the lens of prevention. This is an area where there is tremendous opportunity for collaboration at the state and local level, CDC funds healthcare-associated infection prevention and antimicrobial resistance programs. We fund them in every state and many large cities. So there are over 60 state and local healthcare-associated infection and antimicrobial resistance prevention programs in state and local health departments. They do a lot of work in collaboration with the quality improvement networks and quality improvement organizations. If you're not aware of your state healthcare-associated infection program, really encourage you to connect with your state health department or connect with us. We're happy to put you in touch because there are so many incredible opportunities for collaboration at the local level with these state and local partners who know the facilities, know the needs, and are often looking for partners like you all to help bridge those quality gaps at the state and local level. So please do connect with them if you haven't already. We've talked a little bit about sepsis. That's obviously remains a really important area of collaboration for us, not just on the measurement side, but on the prevention side as well. We know that every year about 350,000 people die of sepsis in this country. There's a huge morbidity and mortality burden to sepsis, and there's a lot that we need to do to improve both the detection of those cases, the measurement of outcomes, and the improvement of care in sepsis. And so in addition to the measurement work on sepsis, we are working on a number of different assessment and prevention tools for sepsis, and we now have them, we have a new tool on sepsis prevention in long-term care. I think this is kind of an underappreciated and under-recognized issue, the burden of sepsis in nursing homes, long-term care facilities. So we have a new resource on sepsis prevention and awareness in long-term care. And we're also working on them in the dialysis setting as well, because that's another really important area for sepsis prevention is dialysis. The other thing I mentioned while I'm talking a little bit about long-term care is our collaboration with CMS to continue to ensure that residents of long-term care facilities are protected from preventable respiratory illness during respiratory season. Remains a really important focus for us. Every year, way too many of our residents in nursing homes succumb to flu, COVID, and RSV because they're not vaccinated. And so really working to continue to ensure optimized vaccination in the long-term care space is an ongoing focus for us, again, in close collaboration with CMS. And I'll close by talking about a couple of newer areas for CDC where we have newer activities. The first is with healthcare personnel burnout. And we've heard it said many times that there is no patient safety without healthcare personnel safety, right? Those are incredibly interconnected. Jonathan Perlin talked a little bit about workplace violence, which I think is a really important issue. The other related issue to some of that is healthcare personnel burnout. And so we have a new assessment tool and a mitigation tool for healthcare personnel burnout that we've made available. I think this is an important domain of work, how we can support the healthcare workforce, which I think coming out of the pandemic is more stressed, more taxed than it ever has been before. And finally, Craig mentioned a little of this as well. We do recognize that diagnostic safety, diagnostic excellence, whatever term you like, it is so important. Working to improve the way we communicate diagnoses is a really important area of improvement. And so we launched last year what we call the core elements of diagnostic excellence. And so this is a resource for hospitals. It was developed in collaboration both with AHRQ and with CMS. And so I think it's one of the very few truly triple co-branded prevention tools that we have. And it's an effort to help hospitals understand the steps that they can take to improve diagnostic safety in those facilities. So I'll stop there, and I think I'll turn things over to you, Ed, to talk about the VA.
Thanks very much. Thanks, Dr. Schreiber, for inviting me to speak, and for CMS for putting on such an outstanding conference. It's been truly professional. Craig, I just wanted to let you know, in the spirit of high reliability and psychological safety, I don't think you got the memo about special socks.
I did not. I did not.
I just want Dr. Schreiber asked me to talk about a little about our journey of high reliability. It was alluded to earlier by one of our speakers who spoke about leadership, process improvement, and safety. That is high reliability, the 3 pillars. So what's the VA doing under those 3 pillars? In terms of leadership, we are focused right now on leader rounding, standardizing leader rounding from the very front line to all the way to the senior level. leadership attention. What leaders pay attention to gets acted on. Their emphasis makes a difference for frontline workers. The attention those people get is important. So how do we make that leadership rounding meaningful and impactful for those people who are impacted, the frontline worker? The second thing we're doing under the leadership pillar is looking at visual management boards. How do we standardize those throughout the organization so that when something at the very front line raises a red flag, we see that flag all the way up at the senior leader level? The third pillar is tiered huddles. We have 5 tiered huddles. Tier 1 is at the facility level. Tier 5 is at the undersecretary level, so that we are transmitting information and solving issues very quickly for our veterans with a veteran-first focus, always veteran first. By the way, I'm a 30-year veteran of the Army. That's why I'm in patient safety. Zero preventable harm is zero preventable harm. I don't want one of my fellow veterans to be harmed, and that's why I do this. The second pillar is continuous process improvement. We have various offices underneath our Office of Quality Management. We have taken, much like TJC has done in terms of a kinder, gentler approach, we have a trigger system for our facilities when they start to not seem to perform as well on quality and safety and utilization management measures, for example. We offer them help. How can we help you get better? What are your issues? How can we help you redesign your systems to capture those data better or to provide better care? So more of a assistance visit. Through our high reliability efforts, last year we focused on, as an organization, an area we found that was particularly problematic. High cost, problem prone, across several of our inpatient to outpatient to long-term care facilities, and that was pressure ulcers. What did we do? We did process improvement. We did not only policy, education, toolkits, and measured it. And by doing that, we're seeing very positive outcomes, because by the time, if you look at the pressure ulcer criteria, you're already at a stage 2 or 3 pressure ulcer, you're too late. So we need to get on the preventative side of that. Recently, the National Center for Patient Safety is starting to coordinate all the falls activities for the VHA. So we are now we're putting out a directive on falls. Falls is one of the #1 harms that come to our veterans across all settings. So we have congressional interest in that as well. Well, we didn't do it for that reason. The reason is our veterans are falling. We need to prevent it. We need to be more proactive in things like deprescribing medications and other technology that can help them avoid falling. The third pillar, I would just let you know, is that pillar of culture of safety. My office is very involved in that. That's team steps. We call it team training. How we eliminate communication errors between groups. Another very large indicator for us of harm is communication errors. One of the leading causes of errors in our system and across the United States. Failure to hand off communication from one group to another group, inpatient to outpatient, outpatient to emergency room, etc., which I think if we have a better electronic health care record will help, and AI may also assist in that area. In terms of that culture pillar, what we've done as part of the National Action Alliance is we have, and our high reliability, marrying them together, is we have put down on a piece of paper a patient safety culture commitment pledge. That pledge basically reinforces the foundational precepts of a strong patient safety program. So that's things like we are committed to leaders investing in patient safety and understanding the importance of patient safety. We understand that root cause analysis teams need protected time to look at root cause analyses. There are 8 pledges. One of those is team training or team steps. We commit to team steps. The reason I mention that is that patient safety culture commitment pledge was signed by all our regions, which are called Veterans Integrated Service Networks, and then all of our facility leaders and the presence of their quality and safety staff, 100%. The link here is that patient safety culture commitment addresses almost all of the domains in the patient safety structural measure that CMS is rolling out. So we're ready. I think we can do better in terms of integrating the voice of the veteran. So I've put a challenge out to my team. It's a subject we've been talking about. We brought that forward as a high reliability organization priority for our next year, along with the other 3 priorities: visual management boards, leader rounding, and tiered huddles. So that is our journey into high reliability. What I would say is it's an enabler, it's a model, it's a framework, and I think it's been a very successful framework for the VHA. So I'm going to turn it over to Marty.
Thanks,
All right, Marty, you've had a lot of time to hear initiatives across the federal government. Are we doing what patients want, and what can we do better?
Thank you, Michelle, and everybody. I would say the answer to that is yes. So I wanted to start by just confessing that this is my 15th quality conference. My first one was 2011, and I've seen a lot of improvement, a lot of things that generate trust over the years of my attending this event, and they've all been consecutive, so I've seen it in an incremental way. I do want to start by addressing the issue of trust, because it's come up several times during this conference, mostly in the context of will patients trust AI? And I think patients will learn to trust AI. The more they use it, the better it gets. I mean, I'm really going to caveat this with the things we've heard about the importance of responsible development of it, design of it, deployment of it, and then monitoring of it afterwards. But if those things are done, patients are already seeing the benefits of AI. Patients are already using it. It's not just the provider community that's using it, it's patients as well, and it is turning up the sort of exciting results that we see. For me, the real issue of trust is stuff that you talked about. We want to see as patients a commitment to a learning community, a commitment to continuous learning from our mistakes, because patients suffer from those mistakes. We suffer grievously from those mistakes. And part of the things that I hear from patients all the time is, I just want to make sure that this is not an experience that goes to waste, that it can be used in some sort of a learning context. I love Don Berwick's comment earlier today about a learning community, not just a learning system. But I do think we have a long way to go there. Starting with the commitment, not starting with it, but just reinforcing that over and over again, because we have to reinforce it as the workforce changes, and we've had so much workforce change. I've been in meetings where the term just culture is not even understood by people in this community anymore, the younger people. And that always shocks me, because it's been such a tenet of the work that we've been doing for years. So hearing you, Ed, say that you're doubling down in the commitment to patient safety just made me happy here. Not just my socks, but it made me happy. I think that's really important. The second part of trust for me is just shining a light on the harm. I mean, every other event I've been to, I think within the last couple of years, I've really tried to say, look, don't hide harm. The more harm is our treasure. The incidents that patients suffer are our learning opportunities, and when it gets hidden, it makes us feel like you just don't want to see it. And so probably the most untrustworthy thing I've heard today is Dr. Bates' statement, and it's not the first time I've heard it, that people are turning off their AI engines because they just don't have the resource or the psychological capacity to see all the harm that they could see if they wanted to. That is not patient-centered. It's not a culture of safety. So I'm going to continue to, not just me, but my whole little tribe of patients here are going to continue to say, look, shine a light on the harm. We have to see it in order to fix it. And then the third piece of trust is including us. And I think CMS has done a very, very good job in that. I mean, we feel included. There have been 3 people from Patients for Patient Safety here on the podium this conference. This is not the first time we've had a chance to come here and contribute to change, because that's really what patients and families, especially ones who suffer harm, want to do. They want to contribute to change. So the more you include us, the more we're going to see what work you're doing, the more trust there's going to be. The second thing I really want to emphasize is diagnostic safety. We think this is a game changer. This is where the core of our excitement on AI is, because there is so much unreported harm around missed, delayed, or wrong diagnoses. And I think not only does that have the potential with AI to find more of it, and therefore to fix more of it, but it's going to be a huge cost savings thing too. So I commend you all on the work that you're doing, and I see it across agencies on AI. I think it's really, really important. Culture of safety, I think I've already covered that. I've made notes all through this conference. But the other thing about diagnostic safety is that it gives us a real way for patients and families to contribute. A lot of the diagnostic safety challenges don't happen in one institution. They don't happen in one visit. They happen over the course of time. Patients and families often see that first. And when we don't have the opportunity to report that in some way, we just feel like the contribution we want to make isn't possible. I mean, this is probably the number one.
Turn up the lights. We have 2 microphones. Let me point them out. Maybe somebody can stand over at that one and wave and show where that mic is. There's a mic over here. If somebody over there can sit and sort of wave where that one is. And we welcome hearing from you, statements, questions, comments. We have just a little over 10 minutes. And Michael, I'm going to tell you, we had a senior official from the Office of Communications sitting in the back who is already researching why there may be difficulties in AI querying CMS data. So that one we are working on.
We can talk about Medicare Advantage and ACOs.
Yeah.
So,
and please introduce yourself to the group.
I'm Michael Mellinson, and I wrote a book a number of years ago called Demanding Medical Excellence, Doctors and Accountability in the Information Age. And my question is for Dr. Srinivasan about the CDC. And I want to build on what my friend Marty Hatlie said about patient suffering and shine a light on harm. Your report on CLABSIs is not understandable by anybody. And I decided to look. So this is a math problem that maybe you can solve for me, because I can't find it through Perplexity AI or through your website, which, by the way, is a document from January 2025 that has not updated the results since 2013, which is not all that respectful for patients. But here we go. Peter Pronovost, in an article in 2010, reduced the median infection rate for CLABSIs by 66% in 18 months. That's 15 years ago. Now, here's the CDC. A 48% decrease in CLABSIs from 2008 to 2013, a 16% decrease, I don't know whether that's additive or not, from 2015 to 2022. And so my math question is, how much have you reduced CLABSIs in the past 17 years, which I can't figure out from what's on your report? Do you have a goal of reducing it over the next, 4 or 5 years, as much as Pronovost did in 18 months?
This data is part of the National Safety Dashboard that we have online as part of the National Action Alliance. And we have data as recent as 2023, and what we've seen is about a 25% reduction in adverse events from 2021 to 2023. So we're making progress. The goal of the National Action Alliance was to have a 50% reduction in adverse events by 2026. So the hope is to get there.
I know we have someone to ask. Just a quick point about patient safety. We could look at systems. We don't do blame and shame. So I just want to bring that out. I'm not interested in blaming individuals. I'm looking at how a system broke down, and we can hold the system accountable and design the system for not only the patient to be safe, but the healthcare team. Because often we design our systems not to the workflow or the structure that the healthcare team needs to do to provide safe and effective care for the patient. So I just thought that was really important point to bring out. That's what patient safety is all about. Psychological safety, to look at systems and processes, stop the blame and shame. If we blame and shame, we will never get to zero preventable harm. Thank you.
Thank you, and well said. Question over here?
Hi, Patricia Kelmar. I'm with US PIRG, the Public Interest Research Group. We're a consumer advocacy organization. We've been around for about 50 years. And we're focusing on high-value healthcare. So obviously, it's the intersection between the quality of care that we're getting and what we're paying for that. So first of all, thanks so much. Learned a whole lot over the last couple of days, and really excited about different opportunities that I see. One would be, I just want to reiterate Marty's comment about people just don't know where to go when something happens and how to report it. And I know Dr. Oz asked us, please tell us, but can you please tell us and help me tell others who call me, like, could we just have a one-stop shop, tell CMS or tell about your healthcare experience email address or something? And we have in CMS, we have the No Surprises Act. They triage, even though it's not necessarily an out-of-network surprise bill, they triage a lot of medical billing questions that come in through their system, through the CMS help desk, to the right entity. So I think having something like that on the quality end of things would really be a great model, and maybe you can work with your partners who run that help desk. That would just be one suggestion. And then also, as I do the work that I do with different patients, we have to remember every single time something doesn't go well or the quality is substandard, it's money out of a patient's pocket. And so I, again, just encourage you to think, you're talking cross-collaboratively right now with agencies and within your own agency around quality. But if you every now and then could kind of do the touch base on the cost end of things, I'm seeing, and I'm excited about, maybe a wellness exam being expanded was one idea. But what I'm seeing from people is they go to a wellness exam, and then they're getting, which they think is a zero cost, right? Zero copay. But all these other things happen while they're there, and then suddenly they have a large bill, and then that makes them hesitant next time to set up their annual appointment. So just thinking about like the quality aspects, but also empowering the patient to be able to financially be protected in some way from the negative quality or unintended consequences of some of these measures.
Thank you. Those are great comments. Anything you guys want to add? Comment?
I want to thank Patricia for raising this fact again and reinforcing that there's no place for patients to go to report right now. So I don't want to blame
the
it.
BFCC?
Pardon me?
Beneficiary care, the beneficiary outline?
There are fragmented places, but there's no place that really takes what patients contribute and report and integrates it into the kind of learning system that I think we deserve in this country. I mean, it just doesn't exist yet. It is very fragmented, and I worry honestly that, with the changes that we're seeing and more, responsibility being delegated to the states, that it's going to get even more fragmented. So it is a challenge that we all have to address as a learning system, but we can do more here. I don't want to shame either Ed. I don't want to blame anyone, but that learning system idea has been around for a long time, and it's time for us to go there. And if it's not going to happen in government, maybe government isn't the right place, then we need to be thinking about how we can do it in the private sector, because it can really help us grow trust, and it can really help us, prevent the harm that is still too frequent. So Patricia, thank you for emphasizing that.
I could provide a brief comment in this domain. I think there are healthcare systems that are innovating in this space and providing patients and families with opportunities to report incidents in real time during their care. For the most part in the inpatient setting where care is most acute, but in a number of different settings. But clearly that's not all healthcare systems across the US. We also supported a research study at ARC where the research team provided patients in the inpatient setting with an app to report events. And what they found in this study that was published in Journal of Hospital Medicine in 2022, I believe, was that patients did use the system. The vast majority of events and incidents that they reported were safety incidents by definition, and only about 1% of those incidents that were reported were captured by the hospital that they were receiving care.
It was one out of 52. I mean, that was the study. 52 incidents that patients reported using the criteria for the incident reporting system, only one of which came through the system. And Craig, I take your point. There are some exemplary systems, but it's not universal. It's why, I think the approaches that we're innovating with here are so important. And I do see them happening, but we just need to make them happen faster. I mean, we've been very patient, I think, in waiting for the change to happen, and we see it happening some places, but just not everywhere.
All right, if you have one comment, because we don't have time for more questions, we're not going to talk. If you have one comment, go for it.
Thank you, and I appreciate this panel discussion. My name is Talithia McBride. I'm with the Federation of American Hospitals.
I didn't recognize you out there, Talithia. Hey.
It's great to see you, and Craig and Marty. So as we're thinking about solutions, and throughout yesterday and today, I've heard technology talked about, I've heard about AI, and one of the things that I'd like to put forward, and especially since we have all of the agencies sitting here, is what is the role of innovation as an extension of workforce? As you know, hospitals and health systems, we experience tremendous workforce losses, and we have not regained that. We aren't recruiting and hiring more people at the bedside. And we had to be creative during COVID in terms of meeting the needs and understanding what we were dealing with. And I think for the most part, we learned a lot. We became learning systems. And what I'd like to see through our programs and through patient safety and how we're measuring and holding hospitals and health system accountable is how are you utilizing this innovation, particularly not just AI, but as an extension of your workforce by the bedside to regain trust, to ensure that the engineering of the system is not failing. And I think that's what we've been talking about here is that the system wasn't resilient and there were some engineering failures. So I know that of systems that are utilizing innovation in a very creative way, are there opportunities to embed that and scale? Because once you start to measure it, then others start to pay attention.
So I think we're going to let you close with that comment, Olivia. And hopefully in the upcoming years at the next CMS Quality Conferences, we can be addressing that. This closes our session, but I want to remind you that we're going to have an exciting final closing here in a few minutes. So please, you've stayed this long, stick around just a little bit longer, but please join me in welcoming our great panelists from across the federal government in patient safety.